All right. So welcome everyone to the poster session on pragmatic trials. So we have 3 posters today, 30 minutes time, so 10 minutes per person. We're thinking about 5 minutes of presentation, 5 minutes of question answer. So I will be keeping track of time, and we'll give you guys some heads up on timing on that. So as everyone is probably well aware, pragmatic trials span across a variety of different health outcomes and things like that, and have a variety of different designs. So we'll be talking about 3 different trials today. So if you can go to the next slide. All right, so the first poster today is by Dr. Amanda Glickman. She's from the University of Colorado and the VA here in Colorado as well. And it is an example of a sequential multiple assignment randomized trial with a study on provider and patient communication and engagement styles. So, go ahead.
Hi, everyone. Can everybody hear me okay? Okay, good. So I want to start by just kind of getting a sense of everybody's understanding of goals of care, conversations. These are ideally happening in the outpatient setting before patients are critically ill. That's often not the case. And that's not good because they're really a very dynamic conversation, and they should be sort of like a process and almost an opportunity for the patient and their physician to discuss their disease prognosis, and sort of like their overarching values in their life so that we can align their medical care. And when those conversations are happening in a crisis situation in the hospital, they're certainly not encompassing all of those deeper values and really allowing, I think, patients and families to express and process this in the best way. So the VA started an initiative 4 years ago, and the idea of that was to try and increase early outpatient goals of care for by giving tools to physicians to aid with those conversations. And so what that was this is pretty small. I don't know if you can see this, but basically it allows you to document a note in the chart that's sort of like at the top of the chart and very visible so that anybody can see that. And then you place durable medical orders. So when this patient's coming into the hospital, instead of the admitting doctor having this quick conversation about their code status or something, these orders are already in their chart and they stay there all the time. So unfortunately, even though this was implemented 4 years ago, we're still seeing that almost 2/3 of these conversations are still happening in the hospital versus in the outpatient setting. So this trial it starts with a low engagement strategy. So it just, ideally what we want to do is test like a tiered strategy. So it starts with a low engagement with physicians, and then they would advance into a more intensive strategy that gives them even more resources. So, and then there's also 2 different patient strategies. So I'll explain what those are. But the criteria to be included in this study were physicians that care for at least 15 or more patients that are at the top 10th percentile for risk of hospitalization and death, with certain serious medical illnesses that, including like COPD, heart failure, end-stage renal disease, things like that. So in the first part of the trial, the physicians are not randomized. So the clinicians all get a low engagement kind of strategy, low intensity strategy. And that is basically an online training module and some written materials that explain what these notes are that they can place in the chart, how to have these conversations, and how to place the orders in the chart. Their patients will then be randomized to either have no preparation for this conversation, so like no implementation strategy needed, or a group with that will receive a letter in the mail about 2 to 4 weeks in advance of their appointment. Then that letter will direct them to this interactive website. It's called Prepare for Your Care. And it kind of, it has videos and different reading materials. It kind of prepares patients to know what questions to ask their clinician to have the most effective conversations. It gives them kind of prompts to start thinking about what are their values and what would they maybe want, who should they talk to, and what documents do they need to fill out. So those will be followed for 6 months. And then at the end of 6 months, we will see we will compare the two groups and see whether physicians have completed at least 4 notes. Physicians who have completed at least 4 will continue on, so they don't get any further intervention. The physicians that have not completed 4 notes will get additional support from their team, and they will get also these prompts. So in advance of their patient visit, they'll be prompted somehow with a list of patients that are appropriate for these conversations, so that they kind of have like a external thing reminding them to set aside time during the visit for this. At the end of those 6 months, we will be comparing the, sorry, I think I'm toward the end, but basically we'll be comparing the group, it's group A and group D will be compared to group B and group E. So basically see whether, like which combinations of strategies is most effective. And yeah, I guess I can take questions at this point.
Have you started the trial, Amanda?
No, it has not started yet.
Okay, I was, if it had, I was interested in the patient adoption of the Prepare for Care tool. I mean, with this population, if you're familiar with the VA population, are they generally willing to do this kind of advanced work before their appointments?
So I think just in my experience, and we haven't implemented the trial yet, but in my experience, I think there's a variable level of, I'd say the biggest barrier is probably like how tech savvy they are and if they can actually like get on this website. But I think I've seen patients find in general these conversations to be really helpful and to appreciate the preparation. I don't know, these patients usually are not like surprised by being told how sick they are, and have sort of tend to like think through these things and be pretty practical. I also didn't have time to say this, but there will be like an additional patient strategy group that will also receive a phone call from a research assistant involved in the trial that will talk them through how to get on the website. So that was kind of another tiered strategy that we're going to implement in the trial.
Thank you.
Any other questions for Dr. Glickman? Okay, I have one. What kinds of pros and cons do you think there are? Obviously you mentioned you haven't started this trial, but what kinds of pros do you imagine this design, the smart design, to have for your trial as compared to other types of trial design?
So the main difference is really that we're going to eventually, I'm getting distracted by a question, but I think the main difference is that this is going to allow us to compare. There's not just 2 groups. So there's 2 different physician strategies, and then there's these 2 different patient strategies. And so ideally what we're going to be able to see is what strategy is the most effective, that's also the least intensive. So it's hopefully going to be, it's basically directly applicable to the care setting. If we don't need the higher intensity strategy, or if certain physicians don't need that, then they can just have the basics, and then you can sort of pick and choose which clinicians might benefit, so that you're using the least resources you can to have the greatest benefit.
Great. Awesome. It looks like we have a few more questions in the chat, and we have about a minute left. So what types of materials do physicians receive, and do they include different communication strategies?
Yes, so they receive instructions on how to like navigate in the EMR, how to literally like do the note and place the orders. And then also we've developed these, this has been evidence-based and tested. It's like a sort of a 6-part question prompt that the physicians will receive that sort of walks you through how to ask different questions in different aspects of goals of care. So it talks about, for example, like, have you thought about who would make medical decisions for you? And sort of what do you have like established, written down? Have you done an advance directive? Things like that. And it goes through different ways of redirecting patients also.
Perfect. Okay, great. Well, we're out of time, so thanks again for your presentation. If we can get to the next slide, please. So next we have Dr. Mark Kowalkowski from Atrium Health, who's going to be sharing an example of a step wedge trial with a study around engagement and management of strategies to improve survivorship in patients with advanced sepsis. So go ahead, Mark.
Yeah, thanks. Thanks everyone for joining today. So I really appreciate the opportunity to present to you all some of the design details of our ongoing trial, which we've called Encompass, which stands for Engagement and Collaborative Management to Proactively Advance Sepsis Survivorship. Just want to note for those of you who aren't familiar with Atrium Health, so it's a large integrated health system in North Carolina, South Carolina, and Georgia, with over 10 million patient encounters annually, and does represent the setting for this trial. So I guess with that, I'll just jump into a quick background for our work. For those who may not be deeply involved in sepsis or sepsis-related work, sepsis is a common and life-threatening response to infection. It can arise from multiple different types of infection. It's the leading cause of hospital death, but actually majority of sepsis patients do survive their hospitalization, and then sepsis survivors themselves represent a really vulnerable population with high morbidity and mortality. And so over the last few decades, many hospitals and health systems have implemented focused quality improvement initiatives to improve early detection and management for sepsis, but really there's much more limited evidence to support effective strategies that address patient needs after the hospital discharge for the majority of patients who survive their index sepsis hospitalization. And so in recent years, recognizing this urgent public health gap, the WHO recently identified sepsis survivorship as an area for increased research and knowledge translation, and then subsequently some best practice guidelines were published with, I guess, recommended targets for post-sepsis care. In some previous work by our study team, we found that these recommended care elements are infrequently applied in routine practice, but when they are delivered, are actually associated with improved outcomes. So that sort of brought us to identifying an opportunity to address sort of the persistent morbidity and mortality and the care gaps experienced by sepsis survivors transitioning out of the hospital. So we developed the Sepsis Transition and Recovery Program, which is a navigator-led, telehealth-based, multi-component strategy to provide proactive care coordination and monitoring of high-risk patients that's really centered around the delivery of these evidence-based post-sepsis care tasks. And for this Encompass trial, our objectives are to evaluate the effectiveness of STAR to improve outcomes for sepsis patients and to examine contextual factors that influence STAR implementation success. So as you can see presented here, the study design of our trial is a hybrid type 1 effectiveness implementation design. The effectiveness evaluation is a 2-arm pragmatic step wedge cluster randomized trial conducted in 8 hospitals in urban, suburban, and rural North Carolina. So each hospital begins in a usual care control phase and then transitions in a randomized sequence to receive additional STAR program support for its patients. And in terms of timing, one hospital is transitioned every 4 months. During months that a hospital is allocated to usual care, hospitals and their providers do not have access to the STAR program, and patients continue to receive routine transition support and outpatient care. However, once a hospital transitions, all of the eligible patients receive additional STAR program support, which is summarized in Figure 2 and Table 2. Specifically, patients hospitalized with sepsis are identified. We have a EHR-based recruitment strategy, so we have an algorithm that runs in the background each day, essentially identifying patients who meet clinical criteria for sepsis. Those eligible patients at STAR transition hospitals are flagged for STAR program enrollment. And we have a dedicated STAR nurse navigator team that follow the patients throughout their hospital course, virtually using EHR communication and phone-based methods, communicating with the clinical teams and the patients and the families during hospitalization, providing sepsis-related education and follow-up information at the hospital discharge, and then monitoring patients at regular intervals over the 90 days, again, via telephone and electronic communications, with a specific focus on the specific monitoring targets that are listed in Table 2, as well as proactive care coordination with the patient's provider teams. And when there are sort of issues identified throughout the follow-up interval, the navigator interfaces with the patient's primary care provider, or also has access to some backup providers that through a hospitalist-based transition services group within our system. So at the end of the primary effectiveness outcome is the composite of mortality and readmission within 90 days, comparing usual care versus added STAR program support. Additionally, we have a multi-part implementation evaluation embedded within the trial at the pre, peri, and post-implementation periods, looking to gather implementation data using COPRH-guided interviews, surveys, and ethnographic observations with various key stakeholders, including administrators, inpatient and outpatient providers, the navigators themselves, along with patients and caregivers. So just jumping, I guess, to sort of the current status update. So we began enrolling patients in July 2020, and thus far have enrolled 1,121 patients through April last month of this year, which is roughly 28% of our target sample of 4,032, and at this stage is on track for on-time enrollment completion in June of 2023. We've also successfully transitioned 2 hospitals to receive the STAR program, and another is on board to start soon. And then from an implementation evaluation standpoint, we have completed pre-implementation interviews with providers and administrators using COPRH. we identified that stakeholders agreed there was a gap in care for sepsis survivors and were supportive of the STAR program as an intervention strategy to address this need. We also identified several facilitators and barriers across many of the COPRH-based constructs, and those are actively being leveraged to adapt ongoing implementation efforts. In conclusion, anticipate that Encompass will provide practical information to advance understanding of how to integrate post-sepsis management across care settings. Additionally, if STAR is successful, this strategy can really alter the paradigm of post-sepsis management for millions of sepsis survivors across different healthcare delivery systems. So just like to thank my collaborators and acknowledge funding from NIH that supports this work. So thank you.
Thank you, Dr. Kalikowski. So we have 30 seconds if anyone has any quick questions for Dr. Kalikowski, and otherwise we'll.
I have a quick question. So you randomized at the hospital level, but then you enrolled patients if they were flagged as high risk. Were you able to waive consent, or did you have to, you're saying yes?
Yes, yeah, we did. We were able to waive consent.
Great, thank you.
Thank you.
Thanks. And then Meredith has a question. If you want to put it in the chat, and Dr. Kalikowski, if you want to answer it in the chat as well, that would be great. And if we can get to the next slide, please. Thank you. So next we have Dr. Lila, Finney Rudden, and she is from the Mayo Clinic, and she's going to be presenting an example of a cluster RCT with a step wedge and factorial design around different ways to improve HPV vaccination rates. So go ahead.
Great, thank you. So I'm Lila Rutten, and I'm going to provide an overview of an in-process pragmatic trial evaluation of a multi-level intervention to increase HPV vaccination rates. For background, despite the availability of effective and safe vaccines, each year approximately 45,000 HPV-associated cancers occur in the US. The HPV vaccine series is recommended for both boys and girls between the ages of 9 and 12. For most children younger than 15, HPV vaccination is a 2-dose series. For children who are immunocompromised or those who receive their first dose at age 15 or older, 3 doses are recommended. Uptake of the HPV vaccine in the US has been slow. It has lagged behind other adolescent vaccines and falls short of public health goals. Provider recommendation has consistently been shown across vaccines, including HPV, to result in increased vaccination rates. So in 2016, the National Cancer Institute issued a program announcement, funding opportunity, inviting applications focused on how healthcare delivery systems can improve the effectiveness of provider recommendation of the HPV vaccine. We secured funding through this mechanism, and we're currently in year 3 of conducting a cluster randomized pragmatic trial to evaluate the independent and combined impact of 2 evidence-based implementation strategies on HPV vaccination rates for our empaneled primary care patient population. We are conducting the trial in 6 primary care sites that provide care to pediatric populations. Using a stepped wedge cluster randomized design, which is summarized in figure 1 on the poster, we are evaluating the hypothesis that compared to usual care, a practice level intervention using reminder recall interventions coupled with a provider level audit and feedback with education will increase HPV vaccination rates in our exposed clusters. Components of these interventions are summarized in the right panel of the poster and highlight some of the refinements and enhancements that were made to the interventions based on patient, or rather parent of patients, and stakeholder feedback. We are using a factorial design, which allows us to use a single trial to test these 2 interventions and to assess each intervention individually and in combination. Our stepped wedge design includes 4 12-month steps to account for seasonality of vaccine uptake. The first step was a baseline period wherein we collected within practice control data for each cluster or each site. And in step 2, 2 of the clusters or sites were randomized to receive intervention 1, the reminder recall intervention, and 2 clusters were randomly selected to receive intervention 2, the audit and feedback with education, or the clinician-facing intervention. Figure 1 on the poster provides further details of this randomization scheme. In the fall of this year, we will initiate the final step, and all sites will be randomized to both interventions. We're also conducting a process evaluation, which involves sending surveys to parents and clinicians to understand some of the potential mechanisms of impact. Specifically, the surveys sent to parents are intended to assess awareness of and response to the reminder recall intervention and to evaluate attitudes and beliefs about HPV vaccination. Our clinician surveys evaluate exposure to and experience with the audit and feedback reports and the educational materials, and also assess provider knowledge and attitudes related to HPV vaccination. So our primary outcome, of course, is receipt of HPV vaccine among eligible patients. And we're hoping that results of our trial and process evaluation will provide evidence showing whether practice and provider level interventions improve HPV vaccination rates and provide insight into some of the contextual factors that are associated with the direction and magnitude of trial outcomes. If you're interested in more details about the study, the protocol was published in Implementation Science in 2018, and you can use the QR code to go directly to that, the bottom of the poster. I'm happy to take any questions.
Thanks for that great presentation, Dr. Rutten. Yeah, any questions, please feel free to unmute yourselves or put it in the chat. I kind of have one. Are you seeing any effects on immunization rates dropping due to COVID and reduced, in-person visits and things like that? And if so, how are you able to, account for that?
Yep, we definitely, particularly when our state was kind of on a lockdown, we had to hold off. Luckily, the timing of our steps start April 1. So we were able to finish our last step at the beginning of the pandemic, and then we held off until September. So ordinarily, we would have started up with our second set of sites being randomized to the interventions, but we held off because the clinic was seeing so many fewer adolescents. And while we haven't looked specifically at our data, because we're still in the middle of the trial, generally there is some evidence of decreased visits, and this is an age group that doesn't come to see the doctor a whole lot anyway. And so we do very much expect, and we're just put in an IRB protocol to look at pre-pandemic rates of adolescent vaccines and during pandemic rates in our larger health system, excluding the clinics included in our trial.
Very good. It looks like we have a question. What change in vaccination rates is this study powered to detect, and does step wedge provide more or less power compared to other designs?
I would have to go dig back through our protocol to remember. Something like 10% is coming to mind, but I'd really have to go back and look at the protocol in terms of how we calculated the power. We work with a really great statistician at Yale, Jeff Heron, who's listed as a co-author on this, who helped us navigate some of the complexities of the pragmatic trial, because we learned pretty quickly that some of the resources that we have internally at Mayo, where we do tons of clinical trials, weren't necessarily aligned to the needs of our project doing this cluster randomized trial. But those details should be in the protocol paper.
great use of a QR on a poster. I love it. Any other questions for Dr. Rutten? All right. Well, thanks everyone for coming today to this poster presentation. You guys can find the posters on the website, on the COPRHCon website, and hope that you all enjoy the rest of the conference.
Thanks, everyone. Bye.